Hi, everybody. This is Chris, and checking my time and calendar. Al, what time is it?
Hey, Chris, I think it's time for another Readiness Rewired, a healthcare preparedness podcast.
And so be it. We've got another guest this week. This week we've got Scott, and we're really interested in visiting with Scott because he oversees a fairly large, multiple facility, um, multiple responsibility hospital endeavor there in emergency preparedness. So, Scott, can you tell us a little bit about who you are and what you're responsible for?
Sure, yeah, and thanks for having me. Been looking forward to this for a while, and good to see you all again. And I'm Scott. I'm the Emergency Preparedness Program Director for a large healthcare system here in Iowa, Wisconsin, and Illinois, primarily Iowa. We have multiple markets, we call them. So we've got hospitals in, for example, Sioux City, Fort Dodge, Des Moines, Waterloo, Cedar Rapids, Quad Cities, Dubuque, and Madison, Wisconsin. And so I've been in my role at the system level of emergency management since May of 2022. So going on a couple of years here, in a couple of months. And my role primarily is support, and then that's how I view it. I don't have direct reporting authority, over the market emergency preparedness folks. They work within their own facilities. They have their own reporting structures. But my role really is, and our system identified the need for the role through COVID, actually. And I can get into that a little bit more. But basically, my job responsibilities are to help standardize processes, efficiencies, identify best practices, help facilitate communication between our markets, and business continuity, which is kind of a newer item on the plate that I'm working on more recently to kind of bring contingency planning a little bit more closely together. So that's kind of it in a nutshell. We have I think about 15 hospitals or so, and about 400 clinics within our network, home care, of course. So
It's a pretty diverse portfolio. And Scott,
yeah.
just so we understand it, are you primarily administrative, or do you also have an operational role? If an incident occurs, do you have set responsibilities, or just kind of coaching the process?
Yeah, I am actually the liaison officer in our system incident command structure. And so if we do have an incident, which we've had a couple since I've been in my role, to the point where we activate our system structure to support the markets, then I am that liaison person. And when we think about liaison, it's not so much that I'm going to be talking to county EMAs or the state so much. My role is more liaisoning with the market EPs, and developing dashboards. If we need to know, what's your bed status, what's your supply status, staffing. Oftentimes, I'll facilitate that information to bring it more in a conglomerate level to the system for decision making. So I'm that liaison with those other Unity Point markets.
Got it. So moving from a siloed, everybody kind of has to fend for themselves. You're helping to kind of grease the communication movement and some of the salient points for the operational response too.
Right. Yeah. And so if system can help support the markets, obviously it's important for us to know what they need help with, and we tend to take an approach of if emergency preparedness starts locally, and it stays locally until we identify that needs to expand, right? And so we don't typically get terribly involved in the system unless the market says, yeah, I could use your help. We try not to interfere too much. We let them do their thing and work their channels. And if we can help support, then we will help support. where there's a need to standardize operations, for example, I referenced COVID. That was really kind of where we identified the need for the role. There were a lot of things to standardize on. There were, as you all know, I mean, y'all worked in it, but visitor restrictions. It didn't make sense for each of our separate hospitals to have different visitor restriction policies. So we standardized across the system. Now, that being said, that did prevent some challenges with, all right, is it better to standardize across the system, or is it better to standardize across all the hospitals in the Des Moines area, for example? And so we had to kind of work through some of those things. But, masking and PPE, that was all driven out of infection prevention, out of the system. We have, infection prevention is there. So making sure that we were all on the same page for masking requirements throughout, and each hospital didn't have to kind of figure that out on their own. Of course, staffing challenges, agency nursing, mostly coordinated out of the system. And of course, that presented some huge fiscal challenges, and still does, with budgeting. So it was important that the system have a big picture of what that was costing us, and procurement of nurses. Messaging, PIO functions, same way, internal, external messaging. Why have each hospital have to come up with their own messaging platform when we can do it once and pass the information down? So a lot of things like that, where we coordinate things at the system level when it makes sense, but at the same time, try to adopt a markets know best approach for their own locale.
So your local markets have some autonomy, is what you're saying, based on the situation and local conditions.
Well, exactly. Yeah. I mean, my only ask really is if a market goes into Hicks for any reason, let me know. And I pass that information on up the chain, and usually it's okay. Well, good to know. Is there anything I can do to help you? Nope, we got it. Okay. Let us know when you need help or you're not in Hicks anymore. And that's kind of how we operate it.
So just so we keep people up on the acronyms for those that are very new, PPE was personal protective equipment, PIO is public information officer, and the HICS that you're referencing now is that hospital incident command system. And Scott, maybe you want to talk a little bit more about that, because you've really taken a focused look at maybe at the systems level how that works.
Yeah. And thanks for catching me on the acronyms.
No worries.
As it's kind of common terminology, right, for us. But,
right.
I know a lot of people don't know what those mean.
That's what we're here for, is just to kind of remind listeners that are new.
Yeah. So in terms of incident command, and we actually call it SIC, System Incident Command, for lack of a better acronym. One of my early challenges, or I guess early needs identification activities, was to develop a system incident command structure that is compliant with the National Incident Management System, or NIMS, as much as possible for span of control and general organization, plain language, those NIMS components that we need to adhere to.
That's a federal thing, right, Scott?
Federal.
I mean, all hospitals
Right.
are asked to comply to that federal standard NIMS. Okay.
Correct. Particularly if you're receiving, grant funding through any source like the Hospital Preparedness Program grants. But, and I really wanted the system structure to be as close to the hospital structures as possible, in terms of the command staff, the operations, the planning, the logistics, and the finance sections. Just the more closely we could align those, the less confusing it was going to be, was my thought. So when we're talking about who's your operations section chief, well, it kind of means the same thing at system as it does in the market. The system structure is designed for it's one of the challenges that I had to think through was communication. And I think you all know that communication is probably the most challenging thing in most incidents, at least the ones that I've ever been involved in. Communication is always an issue. So I thought, all right, there's a couple ways to go. We can either design it so that information flows from the market on up to the incident commander, back over to the system incident commander, back down. That's not the approach that I really wanted to take. I took more of a horizontal approach. So, it's designed so that the system operations chief is communicating directly with the operations chiefs in the markets. The planning chief at system is communicating with his or her counterparts in the markets. It's a very horizontal focus. So that way we don't have to rely on, that game, the start the story at the beginning, and by the time it gets to the end, telephone. Yeah. I didn't want that, and I was afraid of that if we were going to rely on an information up and back down approach. So it's designed for very horizontal communications
and direct parallel communication, position to position. And what education do you provide within your system and within your markets for that, or is that something on your to-do list?
No, we've got a computer-based education module that I developed for everybody who's in our system incident command structure to take. And it spells out, the origin of incident command from the California firefighters. There's a little video on that they get to watch. So they kind of learn the history of incident command, why we use it, why it works, and then it gets into the actual structure itself and kind of breaks out what the various roles and responsibilities are for them. I would also mention that we also added another section to our incident command called IT and intelligence structure. And I've seen that model in some other areas too. I didn't make it up, but it made sense for us to do that because our information technology is system based. It's all based out of UniPoint. Our IT department supports all of our entire enterprise, and so we decided to make a complete section out of that with a section chief and communications, applications, infrastructure, and cyber, actually, directors reporting under that if we need that function. So we actually have 5 section chiefs instead of the traditional 4.
That really makes sense.
And that kind of leads into, Scott, because you've put a lot of pieces. I had some questions. You put a lot of pieces together already, because what I worried about in that regionalization or that larger structure is you have EP coordinators at your sites that some are going to do the leading and take charge. Some are going to want to just follow, hey, Scott, tell me what to do and I'll do it, but I don't want to be the guy making those decisions. And then there are others, kind of like in COVID, where, hey, I don't want to lead. I don't want to follow. I just want to sit here and watch what's happening until I have to do something. Do you see that with all the different individuals? Because I know several of the individuals in your system that I've met, great people, but not everybody's the same, and not everybody wants to take the same bull by the horns, if you will, and kind of make that charge. What do you see on that?
Well, you're absolutely right. There's a lot of variation in individuals' backgrounds, responsibilities. I mean, we've got some people who their entire job is emergency management in their market. We've got others who emergency management is one of 5 things on their plate. Mm-hmm. And those are very different scopes of work and attention, where they can actually put their attention to. So, I think, I haven't really had a lot of challenges in that. In the things that have come up, I'm thinking, we've had long distance outages. We had a contrast media shortage event that, impacted most of healthcare, honestly. We've had some power outage issues last summer when it was extremely hot and we lost power and some chillers and this and that. And I really haven't had issues with the market, emergency preparedness leaders rising to the challenge. They do what they need to do within their own organization. I think the biggest challenge has been, with my role and the system role being relatively new, there's a tendency to, forget to tell me what's going on.
Yeah.
And so I hear about things kind of roundabout, or what you'll have is the hospital CEO or market president, we call them now. they might make a call to system to let them know what's going on. And does that information get around to me? It's always that communication flow piece. And it's not like I'm going to necessarily do anything with the information, but I like to know so that when I'm asked, I can properly pass that information on up and help support. So, yeah.
I had a question about, so in that vein then, much like Web EOC, right, works within states and oftentimes communicates with other nearby states. Have you found an IT platform that you find that helps with this communications piece? And, when you do incident command, are you doing Zoom calls, or have you found a platform that works for you, or, some sort of thing like WebEOC that has got all this data going into it and you can watch it scroll from all these different sources like the county EMA guys? Is there anything out there like that's useful to you?
Hey, so
Uh, yeah,
Mike,
go ahead, Chris.
sorry, just you playing Web EOC. You've kind of made reference to it, but that's a software package that's primarily an emergency management at the government level. Can you describe that a little bit more?
I think you just did it. Yeah, it's just a
Uh,
platform that all the EMAs are using, at least in this state, and they is a constant sort of readiness. You put events in there. You can put comments on what's going on. People can ask questions, exchange information, put in requisitions. I need this. Can you fill this requisition? Okay, yeah, we found somebody that can do that for you. So it's a communications platform too.
interagency, right? Then it's
Yeah.
used between different levels, up and down and horizontally. Okay, and that's actually a commercial product that's out there that's very widely used amongst others. Sorry,
Yeah. No,
Scott.
that's great. Thanks for clarifying. We have not adopted any specific technology for that purpose. We tend to use traditional tools that we already have. So, for example, Microsoft Teams. We
There you
use
go.
that pretty much universally throughout our organization. And the way incident command activation works, or is designed to work anyway, is if it's a market-driven thing. So if it's something happening locally at the market level, maybe a mass casualty of the market, for example, or a power outage. The way it's designed to work is their emergency preparedness leader is to contact me and let me know, hey, we got this situation going on. I'll ask, my first question is always going to be, do you need any help? What do you need from us? And if that answers well, boy, we could sure use some staffing resources or supplies or whatever we can assist with. Then what I will do is I'll take that information, and we have 5 incident commanders at system, and they happen to be our administrators on call. And I will typically just shoot a text to that entire group. Easiest way for me to get a hold of them, honestly, and say, hey, I just got a call from whatever Dubuque, and here's what's going on, and they could use our help. Would you like to activate system incident command? I leave that to them, not my decision at all. And depending on what that answer is, if they decide, yeah, we probably should, then my next question would be, which one of you wants to be the incident commander? And that's going to be based on what is going on. Is it a clinical issue? Is it a supply issue? Different people have different levels of expertise. So one of them will decide to do that, and then I will contact our documentation unit leader in our planning section, and we have that 3 deep, and she will actually send out a message to all of our incident command at the system level contacts. We default to our command staff and section chief roles by default. We'll activate all those.
Yep.
And that was a decision we made. We just, you know how it works. It's a Friday night at 10 o'clock, and you don't want to go through the exercise of, okay, which positions do we want to activate? Well, who's got the chart? Well, I don't know. I don't have it. Where is it at? Back in the office, So we just kind of decided, let's just by default activate down through the section chief level, and then at least we get them mobilized. And what that looks like is it's a blast message out. We use a product called Blackboard Connect for that. That goes out, and it'll basically say, hey, we're activating system incident command due to Dubuque. I'll just use Dubuque as an example, due to a power outage in Dubuque. All right, and please check your email for a Teams invite. Well, that clues them, check your email now, because our documentation unit leader will have sent a Teams invite for a meeting probably in the next 20 to 30 minutes. And we'll ask them to join, and that's where we start our discussion. In terms of pulling the market people in, we will typically only invite the market emergency preparedness leader to that meeting. And their role is to forward that meeting to everybody else who needs to be on that meeting from their market. And that gets us as system out of the business of kind of having to know, all right, is your COO involved? Is your CNO involved? Who do I need to invite in Dubuque? Well, we don't know. I mean, we might in some cases, but we rely on that emergency preparedness leader to make sure that meeting is forwarded to the right people. And then we start our team's discussion, and that's where we will, develop our incident action plan objectives and try to figure out operational period and just try to figure out where we need to go. So,
it's not the first time I've heard Teams mentioned. It sure seems like, from a platform perspective, that thing can be structured however you want it. And in your situation, I mean, I bet that flexibility is really good. My successor has done that where I was working before I retired, and they brought it in from the military, and that's how they did COVID, is using Teams. And he set up, Teams, Microsoft Teams, and structured it like Hicks. It's, each section chief has got their own Teams group, and they have their meetings and they have their communication within their own room, or however it's structured in Teams. And it seems to be a pretty flexible platform that you can do it and apply it to just about anything. I don't have a lot of experience with it. I got to use it a little bit, but sure looks like it could work well.
Yeah. Well, and I guess kudos to COVID, if there is such a way of actually saying that, because prior to COVID, what did we use? I mean, we had in-person meetings, and I distinctly remember my boss at the time sending her team a Microsoft Teams YouTube video to watch, and my initial reaction was, okay, I'll watch it, great, but what's this? And now we use it for everything, and I can't imagine what we do, because 90% of my daily interactions are with people who are nowhere near where I'm at. So it's just weird. It's hard to think back pre-COVID and just all the efficiencies we've gained, and the downsides of all that too. I would say, the in-person, there is a huge downside to it too. But,
right. And the need for redundancy, right? If the networks go down or your ability to access Teams is compromised. So Microsoft Teams has released, I think, a second version of EOC, Emergency Operations Center, kind of software that I think is free to people that have it. But again, it's essentially using, as Mike mentioned, and Scott, you referenced, the channels, files, and basic working structure of Microsoft Teams that people do every day. So they're practiced in it, and just set aside some separate pieces to go to for emergencies. So it's not the only product that's out there, but it's one that people use every day in hospitals in the Midwest, a lot of hospitals, and makes sense. And it sounds like you guys have made a lot of progress with it.
Yeah. I would like to look further at what Mike and Chris, you're talking about with the EOC based, or the more incident command based Teams product. I know what you're referring to, Mike, with your successor, and I would like to see more about how that might work. I'm trying to be a little bit cautious about introducing things that are not in the daily operational structure for people too, because people can only absorb so much. So depending on how different it might look, I might stick with just the Teams that everybody's used to, but I'd like to at least look at it.
Mm-hmm. So Scott, let me take us down a different path, because that's really, I love things, and I've seen the Teams thing at Mike's location where his predecessor has done it. I've been out there and actually observed it, so it is really cool. But you mentioned earlier about the standardization, And when I was in my role actively before I retired, I had 4 facilities, and it was like herding cats. Now, when you get more than 4, like you have, and talk about standardization, I mean, I get the standardization, but policies, everybody wants to have their own little nuance in there. And yet some policies make sense on a campus or a location base, and other policies do make more sense on a standardized, more system level. But have you had some pushback from those separate locations that said, well, no, I need this in the policy and you want to standardize it, but I need my piece. And all of a sudden you make a 3 or 4 or 5 page, very good policy into a 12-page policy that gets so convoluted. What have you seen on that? I'm curious.
Yeah, exactly. Yeah. We've a couple of projects that come to mind that have been big standardization efforts that were quite challenging. One is just standardizing our plain language,
Yep.
our overhead announcement work, and that's something that I was asked to do. Actually, before I formally got this role, I was asked to lead that group. And that was really more around safety, particularly the traveling nurses, and they hear a code, a medical emergency or code blue call. It might mean something different in the Quad Cities than it does in Dubuque or Fort Dodge. And it was identified as a potential safety risk, so they wanted us to look at how do we centralize and standardize what all those codes mean. And in that process, we actually standardized language for fire and severe weather and active shooter and missing persons and decon and all the various things. So that was fairly challenging because we have, a lot of hospitals are, it's working for them today.
Right.
And,
and they don't want the big dog driving their area. I mean, truly.
Well, that's right.
Yeah.
Yeah, that's right. And if I were them, I think I'd probably have the same reaction, honestly. So I certainly don't fault them for that. And we worked through some issues where we just had to make compromises on our end and said, all right, you've got this additional code that you call that nobody else uses. Well, we're not going to tell you to stop doing that. Go ahead and do it, but we're not going to put it on our standardized list. As long as it doesn't directly conflict with something else we're doing. The other piece is we standardized our computer-based learning modules around emergency preparedness. So, every hospital had their own CBL.
Yep.
For fire and, all those things I mentioned earlier. We were able to standardize that across the board. So everybody, all 30,000 or so people at our organization take the same exact one every year around all that. And that was a significant accomplishment that, I was glad we were able to get done. But there are a lot of fragments in the market, some information that they had that's not in the system version now because they're one-offs. And so then we told the markets, all right, you really need to find another way to provide that information. I mean, if you need another local module to cover the miscellaneous info or, and so we kind of stepped out at that point and let the markets deal with that on their own, and I'm not involved in that. But yeah, a lot of challenges with standardization. This year, our standardization focus as far as goals is we want to look at our fire response plans, standardize one fire response plan. I think that one would be fairly straightforward. Race pass. I don't know that there's going to be a lot of variation in how we respond to fires. And the other one is severe weather, and that one's going to be a little more challenging. We've got different protocols on tornado warning response. Patients in hallways versus not. What do? High wind. Are we going to call high winds or aren't we? What do the counties do for 70-mile-an-hour winds above? Do they sound the sirens or not? Which confuses things. So I think the severe weather one's going to be a little more challenging for us. But those are the two we're tackling this year.
Okay.
So.
And RACE and PASS are just fire response acronyms for fire extinguisher management and just general safety approach. So, but good stuff. And you're clearly bringing a level of efficiency, right? That at one level, you're combining all the ideas into kind of a product that you can then distribute to everybody out there. So a lot of them have got to be happy with the standardization because you're doing the heavy lifting. But
Well,
as Al
you
said,
know,
others don't.
it takes, and again, it's kind of that philosophy is how can I be of help? And my pitch is, all right, it takes work to standardize and I need your input, but you will no longer at the market level need to be responsible for your fire response plan. I've got it. And we'll review it every year and you'll all sign off on it. So DNV, CMS, we're satisfying that requirement, but why have 8 separate fire response plans that everybody's got to keep track of and manage and update when we can have one? So that's kind of the direction I'm trying to move where I can.
Right. DNV and CMS again are just acronyms for the surveyors there. And another thing that you've done that's a big lift is in the drills, and those go out and you're working with some of your satellite facilities with that. Can you talk a little bit about that?
Sure. So we identified last year cybersecurity was something that I report through our IT department at Systems, so I have a really good connection there for our cyber work and awareness. And as you all know, cyber is not something that, well, at least in my organization, I guess, has not traditionally been a huge focus for emergency management. Kind of tend to let IT handle that one, but honestly, cyber now is, depending on the year and who you ask, it's certainly in the top 10 on our hazard vulnerability analysis we do every year, our risk assessment. If not within the top 5, it's one of the things that I think has the potential to most significantly disrupt operations. And we're not talking about outages lasting 24 to 48 hours like we typically practice. We're talking about multiple weeks you think about electronic medical records being down for multiple weeks and manual charting and manual medication orders and manual everything. And it introduces some significant safety risks with that if we're not prepared for it. So we identified that as a topic, and we actually designed and ran cybersecurity tabletops in all of our hospital markets last year. So we did 8 of them. Same exercise times 8. So very efficient way to do it. The markets didn't have to develop it. They just had to participate. And this year, our focus is evacuation. And we chose that topic because when we looked at our regulatory compliance scoring against our accreditation agencies' requirements, evacuation is one of the things that across the board we're not as comfortable with as some other areas. Honestly, it's kind of one of those areas that scored lower on our list of readiness and comfort level. And so we drafted a system-wide evacuation plan last year, and got buy-off from all the markets on that. And then this year we're going to do an evacuation tabletop in all markets to test that plan and better socialize it to our market leaders. And I anticipate we'll have some changes to the plan as a result of that. But that's our focus this year. So it's nice because we can again do one exercise, run it 8 times, and the markets, they get credit for it. I mean, that's part of one of the exercises they did. They have to write up an AAR, but they don't have to design the exercise. So that's kind of some of the efficiency we're working on there.
After action review for the AAR.
After action review, yep, an improvement plan. Correct. Thank you, Chris.
Sorry.
Well, I'm glad you mentioned that, Scott, because I'll put a plug in for an upcoming podcast that Chris and Mike and I are working on. We're going to have in the hopefully near future some of our contacts from Department of Homeland Security and CISA, the Cybersecurity Infrastructure and Security group. They're going to be on our podcast. We're working on that right now, trying to get some things tied in. So glad you mentioned that. I'll put a little plug in for those listeners that want to hear about that. Stay tuned and subscribe so we can get you that information. So thank you.
Something that comes to mind with your networks and your different markets, and when it comes to evacuation, if if you all are using the same electronic medical record system, which you are, evacuating from one market to another market makes good sense, right? Just from a continuity of care and ease of care and transmission of information perspective. But given the distances that you deal with, from a transportation perspective, it's an interesting task, because then you got to weigh the benefits of evacuation and movement of patients within markets or from market to market versus the logistical moving of patients that could be going closer to a different facility, but now you're out of your market and you may not be in your same electronic medical records case. I bet that was an interesting draft in each of your markets, right?
Yeah, you bring up something that has been discussed several times, and it's what I can say is the conversation I've been in. Our organizational leadership is number one about what's best for the patient. And so if the answer is let's move them across town to a competitor, that's the answer. That's what we're going to do, because they have the beds, the transportation, logistics. It makes more sense. That being said, there is some efficiency and safety to be gained from staying within your own charting system and processes and that. So it certainly is a balance, but we certainly would not compromise any kind of patient safety for the sake of trying to keep things within our system at a greater distance than what we could do locally if those beds were open locally. So I think it's always going to be about doing the right thing.
Oh, absolutely. Yeah. It would be interesting, the intricacies within each market and what they have to work with, and the folks they may be able to transfer to may not be the same in another market. They may not have the same types or numbers of facilities to transfer. So that variability would be very interesting to work with.
Yeah. Well, and as you know, the EMS resources aren't, or emergency medical system, ambulance resources aren't necessarily
plentiful.
Plentiful is the word, yes, to be transporting lots of patients long distances throughout the state either. So
yeah, and then it gets down to the patients, like you say, individual patients too. You may have individual patients at your level 1 going, oh my God, I can't send them except to another level 1. And that may be out of state, maybe closer. And so it gets really interesting.
Correct.
And all this evacuation, to talk about evacuation and the cybersecurity kind of lends itself to a concept that's been discussed recently, emerged in some of the regulators' language, and that's business continuity. How are you guys addressing the business continuity concerns that regulators are now looking at for evidence of?
Mm-hmm. And I'm curious to hear. I'm glad Gris brought that up. You mentioned earlier, Scott, about business continuity, and I'm curious to hear your honest perspective on business continuity, because I mean, it's great for Walmart and other things. I have a harder time fitting it into healthcare the way the surveyors, the DNV, the Joint Commission, those people want to try to fit it in and spend that much time and that much effort on what I kind of refer to as BCBS, business continuity bullshit. Because, and again, I could be wrong, and but I just don't see spending a lot of time on putting a business continuity plan together when you mentioned all these other plans. We have a fire plan, we have a tornado plan, we have an active shooter plan. Those are all business continuity pieces that come together. I'm curious to hear your thoughts. And again, I could be way off, and people are pro business continuity. I'm not.
Mm-hmm. Yeah, I've come a long way in my mind on the business continuity piece. When I was first, it is in my job description to oversee the business continuity program. And at first I was kind of like, well, how does it differ from emergency preparedness? We've got all these plans. Well, there is a significant difference in that most of what we're planning for emergency preparedness is life, property, and environment. I mean, in that order. We're planning for, the immediate response and relatively short aftermath of that. Business continuity, I could show you a scale that I'm thinking about in my mind. But business continuity takes the part that we're doing and brings it out here. To a hospital may get through an incident, but then may go broke a year later because they didn't have the continuity pieces in place. The ability to continue to pay your staff, payroll goes down. Well, what's your backup plan? The ability to bring in revenue. We've got days cash on hand in our facility, but if Epic goes down for a significant amount of time, how are we going to bill anybody? Well, how long can you sustain that? Now, I think of that as a finance revenue stream problem, and it largely is, but it ties into our hospital's ability to sustain our operations. So from a business continuity standpoint, we're already doing a lot of things related to business continuity. Our 96-hour sustainability plans that we're required to do every year. That, to me, that's business continuity.
Right.
If you're doing them right, you're looking at your resources. How long will they last? What are you going to do to conserve resources if you need to? I would say that where business continuity ties in is with that process is what are the essential functions that you need to sustain to keep your hospital running? Those we generally have not well defined, in my opinion. We tend to operate from the standpoint of, well, everything's essential. We got to keep the whole hospital functioning. It's like, no, you're wasting your time if you think that you're going to devote all your resources to keeping your entire hospital running when you really need these 5 or 10 things running. It's kind of like a patient surge, right? You can't provide full comprehensive testing and medical care when you got 200 people coming in your ED for mass casualty. You got to back off of that. It's the same thing with business continuity. So what we're doing with that is, I look at it like, all right, if the lab, for example, identifies that they need these 4 software systems to continue to run, absolutely have to have them or they're going to shut down. Well, IT needs to know that because those are the 4 they should be focused on. Don't focus on these other 8 that don't matter, that the lab has contingency plans for. And that ties very directly into emergency management, in my opinion. It's identifying your critical resources because that's going to extend the ability for your hospital to get through an incident, which is going to then come back to emergency management and all of our HICS structures, and you know what I mean. So it's very much tied in. It's a hard nut to crack, though. It's a big endeavor.
Well, I believe in business continuity. When someone comes up and show me your business continuity plan, it's like that plan, if well written, could be 382 pages that we spent 3 years on. It's the business continuity concepts are wonderful. It's how do you put that all together? And I say, because your 96-hour, all your other plans, they all come together. And you bring up some good points in billing and payroll and those type of things. Yeah. But how do you write a plan? It's more conceptual, and where the incident command team comes in and says, okay, we have to make that battlefield decision. Here's what we got to deal with because here's the information, So I like business continuity. Don't get me wrong. When I hear somebody working on a document that's a plan, it's like I kind of roll my eyes and think it's never going to cover what you're going to be dealing with anyway. So
yeah. The document isn't as important as the strategy.
Yes,
strategy. You have to have something
I like that.
documented, and my thing is, all right. I think where the balance is, we're constantly trying to achieve efficiencies through AI, for example. How can we do things smarter with fewer resources, more globally?
You bring up a good point about AI, Chat GPT and AI. Us old guys, we didn't have anything like that to work with.
Right.
Now you can go out and have AI say, hey, draft me a business continuity plan for a 25-bed critical access hospital in the Midwest. And it produces something for you. It used to be you had to call up your buddies over in the next region and say, hey, man, you got a plan you can share with me? And you beg, borrow, and steal. And we're all good at that. That's how we do our jobs. And we
Yep.
willingly, share and, shamelessly steal from other people when they willingly let us. But, AI gives us a whole new perspective on how to obtain things. Yeah, we never had that.
And I think the business continuity concept kind of came to a head for hospitals during COVID, right? When it was supply chain disruptions and then we were closing down and focusing on essential operations for emergency departments and so on. But surgery and other areas that were major revenue producers, when you close those down, your true sense of essential operations kind of shifts over time. So, to Al's point, it's a big, sprawling, complex issue with a lot of different, I think, impressions and definitions about what it means. And I think this is going to be important for emergency preparedness and emergency management folks to understand what does business continuity and business impact analysis and disaster recovery, what do those mean, not to your own words, but organizationally. And it sounds like your enterprise has taken that on and tasked you with building that out.
And I like what
Yeah.
Scott said with strategy. I love that. It's not a plan, it's a strategy. And that makes sense.
Yeah, and just to clarify, my charge this year is to develop a business continuity strategy recommendation for organizational approval or not. Um, and so I'm kind of in a mode of gathering resources, educational materials. What's reasonable given the resources we have? There are a couple approaches. The resource intensive way would be to go into every department in an organization and require everybody to do a BIA, identify their essential functions, all the resources, roll all that information up with dependencies and roll that to a higher level to figure out what our critical operations are. That's super resource intense, obviously. I mean, I don't know how many departments we have, but 1,000, or more, and getting everybody to do that. And some of those departments, honestly, we know they're not probably those critical functions
Right.
anyway in a true disaster. So my approach really is to start at the top and let's list out intuitively what we know are probably our most important things. And I would argue that our infrastructure is number one. If you don't have a building that you can operate in, you have nothing. So I've prioritized infrastructure, utilities as the number one thing for our organization. Number two, staff. If you don't have staff, you have nothing. And you kind of go down the list, and you could argue, the order of some of these things. But then once we identify things at a high level, then let's do a deep dive on our facilities infrastructure and find out where do we have vulnerabilities and where might we need to invest. And that's a more doable, reasonable approach to business continuity than let's ask our wellness department to do a BIA analysis, and nothing is wellness. I just picked them, but their fitness center probably is not real high on the list of long-term emergency response kind of thing. So that's kind of where I'm at. I'm also honestly that 96-hour sustainability document. I'm revamping it. We decided to standardize that this year, and I'm turning that into more of a business continuity document.
Okay.
At least that's my approach right now. So, for example, I know you're familiar with that, but generator fuel. How long will our fuel last? And you're used to those calculations, and you list it out, and how many hours can you sustain your fuel? Well, I want to add some elements. Okay, if you run out of fuel, if you get low on fuel, I want you to list here what are your mitigation strategies around that. How are you going to conserve fuel? What's your plan when you do run out of fuel? You lose power, I guess that's not a good one. Maybe that's a bad example, but I want all this information to be in this 96-hour document. And to me, that'll be a good precursor for a business continuity plan, because we can use that and say, look, we've got our resources identified. We know how long they'll last, roughly. And by the way, we've also listed out all of our strategies to help conserve these things.
Yep.
And here's our MOU. Here's who we're going to contact for our MOU. I want to put all this in one spreadsheet, and I think it's doable.
That's what we did with our 96 hour. And the scariest thing that came out of all of that was medical gases. Oh my God. How long can you be sustaining your hospital operations if you got a medical gas issue? That is the one that kept me awake at night so often, and actually prompted us to put emergency medical gas backup hookups in newer facilities that we construct, so you can bring a semi in and hook it up to that emergency connection to be able to backfeed your medical gases. So you're right. If you look at your 96 hour, oftentimes that red bar that appears, that first one, really tells you where your priorities were. And boy, medical gases for me, that just scared the crap out of me.
I'll make note of that.
Hey guys, 96 again. We need for new listeners. 96 hours is using that terminology. Originally was 72 hours, right? Then 96 hours was something that came about mainly, I think, or most prominently during the hurricane debacles that we've experienced, where it takes about 4 days for federal resources to muster and land at your site. So what can you do in those 96 hours? What can you continue and not continue? And so there are templates out there that of various degrees of sophistication that people use to help go through the staff, the supplies, the systems, the support that they have, or what are the alternatives?
Said it. I think it's time to wrap up this Readiness Rewired podcast.
Okay.
Really appreciate
Thanks.
you coming on, Scott. Outstanding, man. Always
My
been
pleasure.
a pleasure to work with you, dude. And
Yeah,
you still
likewise.
like to hang out with us old guys
Yeah.
every once in a while.
In our basement bunkers.
Yeah.
Yeah, long history with all three of you, and it's great to see you and work with you. So anytime, I'm glad to help wherever I can. So
Just want to remind everybody, make sure you click that subscribe button. Give us a thumbs up if you like it. Give us a thumbs down if you think we suck. And make sure you ring that bell so that you know when we put up another video. And reminder, our email, readiness.rewired@gmail.com. Happy to hear you. Any comments, any suggestions for the future? We want to hear from you.